Across the rendered fundus image is the exact scan that you're seeing here. And in the bottom right corner, you can see the three-dimensional image. So the reason this can be important, especially if your imager or your photographer is not very experienced and you have a patient who can't fix it, if they just print out one scan and you see this, you make the diagnosis of macular edema. But if you look at additional scans, you see clearly this patient had a macular hole. This one looks like central serous. But when you scan through, you can see as we're scanning through the bottom of this lesion, it looks like central serous, but then clearly this is an unusual appearing macular hole, almost a double macular hole. I'm not going to talk at all about glaucoma. You'll hear about that shortly. Nor am I going to mention anything about anterior segment scanning, just to show you a couple of quick images from the anterior segment scanning and measurement of the angle and doing pachymetry. And very soon the software is going to allow you to diagnose keratoconus, hopefully automatically. So just a few quick words on the analysis features. So again, the number of data points in the EMM5 is very great. Allows you to do more accurate analysis, because even if one of the scans was inaccurate, it can be averaged out from the others. This is an example of the redrawing of the boundaries. If you see up here, notice the white line does not correspond to the inner retina, so the machine read the inner retina wrong. You can automatically do a redraw of that boundary using the cursor, just drawing right along the surface. And that makes the scan, obviously the measurement, accurate. Other tools that are available, you want to measure any type of thickness by manually, you can. If you're interested in measuring areas, for areas of a macular hole to predict success of surgery, that can be done as well. Symmetry between eyes is available, and progression analysis is available. Once again, the progression analysis is based on registration of the blood vessels from visit to visit. You can track up to 4 different scans. And the difference analysis can also be shown as color-coded. Where you see the red, that's where the retina was thicker from the second scan to the first scan. Where you see the blue is where it was thinner. The difference analysis can also be done as part of the RPE change, if you like. If you want to follow a patient with macular degeneration who you're treating and they have a pigment epithelial detachment, you can measure that also. So here's baseline, and here's the RPE elevation, and this patient is treated. You can see very clearly, we all agree that subretinal fluid is gone. But if you're wondering what happened to the pigment epithelial detachment, you can see qualitatively it's less, and the machine will measure the difference for you if you're interested in following your patients with pigment epithelial detachment. Volumes can also be used, and I mentioned this threshold volume, which I think is quite helpful. You can define up to 500 microns. Over here, the threshold that you define is abnormal. Typically, we choose 300 microns, and anything above 300 microns is abnormal. So here's an example of the threshold maps. This map here is not a map of the thickness of the retina. That's up here. What you're seeing here is everything that's over 300 microns. And this is before treatment and after treatment, and you can see how virtually all the retina now is less than 300 microns. So that's an ability to average, take the 300 microns as normal and completely remove it from the macular map. In the interest of time, I'm really only going to show you a couple of cases. Before and after macular hole. Bottom is before, top is after. And notice, as we often see, there's a little bit of fluid still. I'm sorry again, I apologize, my video's not running. AMD scar. No video from that one either. going to make my case reports very quick. This is a patient with vitreomacular traction syndrome. And you can see it appeared that there was a little bit of inner retina still present. So that's on Stratus, and that's on RTView. And we put him into the RTView in order to do three-dimensional scanning. Because I wanted to see if there was any part of the inner retina where there was a break. Because if there was, I was going to operate, and if there wasn't, I was going to watch. I think you may have to take my word for it. There was no break. Take my word for it. Now, this last case, obviously a case of idiopathic juxtafoveal telangiectasias, and an interesting three-dimensional scan as you scan through it. So, let me conclude. The advantages of the Optovue system: the normative database, best normative database of any of the machines. Individual patients, you can optimize the setting to get quick, optimal quality scans for each patient. The real-time scanning is very useful for your operator, your imager, because they'll know if the patient isn't fixating or is blinking a lot. You can segment various parts of the retina if you're interested, including the pigment epithelial detachment. This is the only machine that allows you to segment and look quantified at the fluid in the sub-RPE space. The elevation and deviation maps are very good from visit to visit. The progression as well. This threshold volume map, I again find it very helpful in treating patients with macular degeneration or macular edema to know how much of the retina is still thickened above normal. There are various ways to look at the three-dimensional images, either as a video or as on FOSS. And again, the glaucoma scans and the anterior segment scans, you'll hear more about that shortly. In my second to last slide, I just want to mention where OCT technology is going. Theoretically, with the right light source, axial resolution can be lowered down to 1 micron. We have a 2 to 3 micron prototype machine in our office now, and theoretically we may be able to go down to 1 micron. I mentioned faster speed, up to 300,000 A scans per second. I don't know if that will ever be commercially available. It may not be useful to scan that fast. But scanning that fast allows you to do some very interesting things. Like you can do Doppler by just taking multiple volume scans over and over in the same place. And the only difference that you'll see in the scans is the moving blood vessels through the capillaries. So you can get Doppler imaging without truly doing Doppler, just by doing it very rapidly. You'll also be able to have a tracking system without having a true tracking system, because the machine will work so fast that any small eye movements, even movements from the beating of the heart, can be averaged out at that speed. Adaptive optics is a system that you may hear a little bit about shortly, but adaptive optics is a system to improve transverse resolution, and this can be applied to any optical system. So Doppler OCT is available now as true Doppler. The faster speeds will allow you to do it more elegantly. And finally, functional OCT. It's now, with the speeds that the OCT prototypes can go, you can now measure changes in the outer retina as photons of light are absorbed. So an OCT is done, and the light from that initial OCT produces changes in the photoreceptors as they absorb the light. And an immediate OCT is done right afterward, very rapidly, and the changes can now be measured. And we'll see whether the functional OCT will help us diagnose disease earlier. So in conclusion, the RTVue is a new spectral domain machine with a more comprehensive data set, more accurate quantitative analysis, excellent normative database, and I think now in 2010, spectral domain OCT really should become part of all of our practices. Thank you very much.